The mid-face is actually one of the most features that make us look older. Because when we age, we have a lot of stuff that's going on our face. The bone ages. When the bone ages, a lot of bone gets resorbed. So our face looks hollow. It's not supported anymore. Also, our fat pads. The fat pads get shrunken, and other areas like the lower face, the hypertrophy, along with the sagging of the face ligaments. All these three components make our face look very, very hollow in the upper part, saggy, and apparently heavy in the lower part. This gives the inverted triangle that we are looking at in the old age. These are the ligaments. I'm mentioning here the ligaments because they are very important in our work in the mid-face. We are going to work by two ways: ligament lift, which is the lifting method, and volumetric method, volumizing the atrophic fat pads. Okay? So when we are looking at these ligaments, we are finding them, all of them, they get saggy with time. When we are going to do the ligament lift in the mid-face, we will mark each area of this ligament and put a pillar of filler to support the ligament along with filling the atrophic fat pad. So, let's take a look at this mid-face, which we see every day. What's happening actually in this mid-face? The infraorbital and the anterior cheek fat pad are atrophic, so we lost the anterior projection. The patient looks hollow from the front. Also, the orbital bone gets resorbed with time, and the infraorbital fat bulges. This is leading to the tear trough area. The fat herniation through the muscle gives us the eye bags. So, in this case, we can find both sagging, giving the nasolabial fold. We can find this area of hollowness. Okay? So we need both methods, ligament lifting and volumetric restoration to the cheek. We must follow the anatomical fat compartments and the ligaments landmarks to get our best results. Okay? Now, let's see a real case. This female, 38 years old, the same case as the before. We can see the sagging face, which is not too much, actually more like atrophic fat pad, the herniation of the fat in the infraorbital area giving the eye bags, and the tear trough is very evident, right? So, when we are marking the face, we are marking three parts. This is the point of maximum projection. This is how we get it. This is the point of maximum projection, which gives us the lateral projection. And this is the point of the anterior projection. Here, we need the fat restoration. We need volumetric method. Okay? So we are going to do the ligament lift here and the volumetric here to get restoring the whole face. Now, I am going to do first the boluses with a needle on the bone. As Dr. Yahya said, the lateral area has nothing. I pull the skin upward. I am injecting directly over the bone, over the zygomatic arch. This is the point of maximum projection. I put the bolus. I massage it upwards, and this is very important. Okay? Then I mark 1 centimeter behind it. I reach the bone, I touch the bone, and then I inject another bolus while lifting the skin. I'm lifting the skin to lift the ligament. And when I'm lifting the ligament and putting my pillar bolus of filler, this gives lifting. Now, this area. This is the dangerous zone of the face, okay? Now, what is dangerous in this area? What's the danger structure here? Yeah, the infraorbital vessel. So we have to mark our danger zone. The infraorbital vessel is just medial or in the mid-pupillary line, 1 centimeter below the infraorbital margin. Okay? So I mark this area. We will see it later. I'm sorry, it's behind this. but we will mark it. We will be lateral to the mid-pupillary line and below this level. And we will reach the bone to put our bolus and then push it to the area that we cannot reach by needle. This is if we are working by needle, and we will see it again by cannula. But we have to be very specific. Here you can see I am lateral, I am entering, I touch the bone, and then aspirate. When I aspirate, I wait, and then I start injecting very slowly. And it's not much, because I'm just supporting this area for the bone resorption, and then I will continue my work with the needle. If you can see here the patient, the area is lifted and it's becoming shape, the contour of the cheek. These are the same points over the zygomatic arch that we are going to do for even a young patient with no atrophy that needs contouring of the face. We sometimes find patients coming to us with a flat face, okay? Very young patient, but she has no prominent cheekbone. We need to give her contour. This is called contouring. It does not take much filler, only half a syringe on each side. We put boluses over the zygomatic arch, we touch the bone, we put our bolus, and then we pull it upward. We actually paint or draw or sculpt the new zygomatic arch to give the contour for the face. See, the patient is already becoming elevated, but still hollow, because this area in the malar fat pad is atrophic, and I cannot fill it by just going over the bone. I need to go to the superficial fat layer. So I'm entering with a cannula. This is a 25 gauge cannula. If you're asking, I work by 25 or 23. Actually, I prefer 23 to be more even safe. With the cannula, I can reach the malar fat pad, I can reach the deep and the superficial, and I can even push my cannula upward to reach the medial souf, so I can support the tear trough. And we will see, this patient, I did not do the tear trough at all, and we will see later how much she improved. When you find a patient coming to you with the tear trough, see my finger here, this is very important. Put your finger here to protect the globe. If you are going up to the souf, put your finger to protect. Now I'm pushing my filler a little bit upward to fill the area. Now, from the same entry point, I'm going to do the whole area. I will show you here. I'm going now laterally. Remember when Dr. Yahya said this is the artery area? I am going with the cannula to be safe. I'm filling this area, which is hollow, and I am also lifting the face by this technique. I'm filling now the superficial layer. Take care. This is only taking less than half a syringe for the rest of the cheek, for the superficial area. I'm not using much filler here. I used half a syringe for the deep, half a syringe for the superficial. The whole face, it took 2 syringes, one for the right side, one for the left side. That's it. We did not put much filler, but we had to put it in a good distribution. The cannula gives us this look of smoothness. We can restore the OG curve by going with the cannula. And I set the patient in the middle of my procedure to see if the volume is enough, I stop. If I need a little bit more volume, I go. Now also with the cannula, I can reach this area, the piriform space that Dr. Yahya told you, it's very dangerous. I can reach it with the cannula. I can even from the same entry point, go with the cannula to reach the nasolabial fold and put a little bit of filler to fill it. So I did not make too much entry points. I did not use much filler. I just put it all over the area. All my massage goes upwards and laterally. Upwards, the lifting, This is the filler I am massaging now. See? This is immediately after. We can see the face lifted and it's filled. But I will show you better now.